Virginia, Mr. Griffith, 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate my colleague mentioning that we have to look out for folks who might have different accents. I thought maybe he was talking about me. Yeah, he says yeah, and others. But I do appreciate that because this is a good program, and I think we all acknowledge that. But Dr. Pat, I agree completely, and that was the dialogue I was having with my colleague from Vermont earlier, that we need more transparency. We need to see where these savings are going so that we can make sure that this money and the intent is going to where we intended it to go. It may not go directly to patient A, but it ought to be going to patients in similar circumstances as patient A who's entitled to a benefit. So I appreciate your comments on transparency. We'll see what we can do to make that happen. Dr. Daniels, I noticed in your answer on, what is it costing the taxpayers? You said it doesn't cost the taxpayers directly, which I agree with. I think that's, or close to agree with. But let me see if I can clarify for my own edification and education. So if you're receiving Medicaid, Medicare, which is taxpayer benefit, and the hospital receives a discount for the drug, don't they still bill Medicaid, Medicare? And I'm not saying it's wrong, I'm just asking to get educated. Don't they still bill Medicaid, Medicare for the full cost of that drug?
We certainly bill according to the contract that we have.
And that would be the way the 340B works, though, isn't it?
Yeah, I think we follow the rules.
And I'm not being critical of that. I'm just trying to make sure that, so that would be a little bit of direct money, and then the indirect and the costs may be shifted elsewhere. But I appreciate that. My understanding, and correct me if I'm wrong, and I'm looking mostly at our hospital folks, not Dr. Pat in this one, is that the child sites, those sites where a company has come in and purchased a practice, the child sites are actually growing faster for 340B in the last several years than have been the parent sites. Is that not correct?
That's correct. We have, I think, 83 child sites. And the way our child sites work is anything we have off campus, so we may have one building with 5 different clinics on a floor, that's 5 cost centers and 5 child sites. So as we, like we're dealing with now, we have a behavioral health problem and we're trying to add some services and an extended observation unit, that'll be a child site so we can get access to drugs to treat those patients.
But that's industry-wide as well, isn't it?
I can't speak for the rest of the world, sorry.
How about you, Dr. Daniels?
Yeah, just affirming that statement. If we have in the same physical space, if on Monday we have cardiology and on Tuesday we have endocrinology and on Wednesday yet another clinic, each of those would be registered as separate child sites. So we follow the HRSA rules, and that part of the large number of child sites is related to the fact that that's the requirement in order for us to be able to meet the HRSA rules.
Yeah, and I think one of the concerns, we had I don't believe it was this subcommittee, I believe it was one of my other subcommittees, we had a hearing previously on this same subject area, and one of the concerns raised in that was a lot of hospitals were buying oncology sites in order to bootstrap or beef up their 340B capabilities. Dr. Pat, can you speak to that?
I can. You've seen almost 700 community oncology practices close or align with hospital systems in the last decade, shifting the cost of the site of service. And so let's say you have a hospital and 2 community oncology practices that are 30 to 35 miles away in a suburban area. If those qualify as child sites where it's, the payer mix is predominantly private and Medicare, it allows them a tremendous economic advantage. And so because they have such, an arbitrage opportunity with purchasing power, it's really easy to say, hey, community oncologist A, practice A and B, you can either align with us in the hospital system and let us purchase you, or we're going to open something right next door, and I can see half the patients because I can bleed for years because I have 340B discounts. I buy drugs at half the price, and we're going to push you out of the market. And so that's happened to almost 700 community oncology practices. And so, it certainly alters market dynamics. And while I would say it's not great for community oncology and not great for some rural sites that have closed, but more so shifts the site of service to a more expensive cost of care. And so, we'd love to see some of that economic incentive be diminished over time. And I think that happens when you provide transparency, accountability, and appropriate patient identification, because then that you can show sunshine on the behavior that that qualifying entities have, and then make sure that it's alignment and value add to underserved patients. And so I think that those are things that are in the best interest of healthcare in general.
I appreciate that. I see my time is up, and I yield back, Mr. Chairman.
Chair, thanks, gentlemen.